Hello, everyone. Sorry, I can't do this in person. I'm covering the night shift at the Royal tonight, and I didn't fancy going through the snow twice today. Um, I'm going to talk a bit about spinal cord injury. So, as you can probably see, that is the least necessary arrow on an MRI ever. Um, this is an uncommon presentation to ITU. So, um, the latest stats I could find is there are about a thousand-ish cases a year in the UK. So it's not particularly common, but it's quite a high stakes problem, and it's something that we can add a lot of value to on ITU, and demands a little bit of careful thinking and a change in how we do things. Um, so to start, let's see if it can go through. It should be going through my slides now. Um, so a few things when the patient comes into ED, because we tend to get called for these quite early. So in terms of risk factors, nice kind of splits that you've got the high risk factors and then which push you towards CT, and then you have the low risk factors that push you towards being able to say it's fine, at which point you'd hope they wouldn't call us. So your high risk factors, so your elderly patients. So as we kind of know, the context of silver trauma, those patients over 65 years old, what could have looked like a fairly low velocity injury due to kind of existing wear and tear can actually cause quite a significant damage. So they tend to get CT. Anyone where there's a dangerous mechanism. So essentially, this is that fall from greater than a meter of 5 steps and axial load to the head. And I've got a nice example of what that looks like in a second. All those with paresthesia in their upper or lower limbs, I think it's fairly straight to say in the context of trauma, they're getting a scan. When you get into your low risks, it's kind of what you'd expect. So they're in a minor rear end motor vehicle collision. They're comfortable sat in a sitting position. If they've been ambulatory since the injury, it's unlikely they've got a large spinal cord injury. If they're not tender in the midline of the neck, and then delayed onset of neck pain, and then it's less likely. You tend to get that pain and what we used to term as whiplash setting on kind of hours afterwards as you go into muscle spasm. That's very close to what an axial load looks like. Yes, that is me. Yes, that hurt. So very helpfully, that ring around the helmet of where the vents are, just there. If you land there straight on the top, then essentially all the force that's going through your neck is then transmitted directly through your spine. That then tends to cause it to buckle, and that's where you get the kind of the really drastic injuries. So if you hear my neck cracking when I'm ITU, this is because I made some silly choices earlier in my life. Going on. So in terms of the pathophysiology and what we're actually trying to achieve when these patients come to us. So you obviously have your primary injury. So you've got this direct traumatic damage to the neural tissue itself. But really, well, there's not a lot we can do about that. Really, where we come in is trying to prevent further secondary injury. And there's a few different mechanisms for this. So any hypoperfusion, whether that's due to further compression or like poor blood supply to the area, and hypoxia in the tissue is going to lead to a further ring of damage. Lipid peroxidation, again, causes further damage, and inflammation around the cord itself, again, spreading to further damage. And where we come in is trying to prevent this occurring. And then you've got the management of associated injuries. So it's uncommon that these present by themselves. So obviously the most kind of the two probably most common presentations in the UK are road traffic collisions, or kind of falling from height. So someone working on the roof, working in a ladder tend to be the two we see. Thankfully, we don't see many gunshot wounds, so we're not going to talk about that one. But managing those other traumas, managing injuries to the vertebral artery can be quite complex. I'm not going to talk much about the context of polytrauma here because that's a talk very much in itself. I'm going to swing back to, let's say we have a confirmed spinal cord injury, what are we going to do? Or at least strongly suspected. So we've been called down to see this patient in resus. What's our immediate priorities going to be? So it's that CABC response that has been kind of taught through us all the way through med school. Okay, so we're going to resuscitate the patient first. Then we need to have a look at an accurate assessment of what the deficits actually are and try and localize where the problem is from there. It's on management and prevention of secondary injury, and that kind of includes these three things really. So that may be stabilizing with decompression if it's appropriate for the patient. I'll talk about that again in a second. Making sure we've got adequate perfusion to that tissue itself. And then in the more medium to long term, how are we actually going to rehab this patient and start that process? Obviously, management of other injuries comes alongside that. And then brief talk about imaging. So the first bit that you see ABC. So C-spine, essentially is fairly straightforward. You're looking at full spine immobilization until a full assessment can be carried out. So an unconscious patient, that's not going to happen and you're going to have to go to imaging. But we're looking at full spine. So that's log rolls for any turns. That's on your boards. That's your kind of collars. And the next question is going to be, do I need to intubate this patient? So which patients are we going to intubate? Well, the ones with reduced GCS, yes, I probably am, as I would anyway. If there's clear direct trauma to the neck or any penetrating trauma to the neck, then yes, I'm probably going to want to intubate and protect that airway. Any patients where we're expecting a lesion that's going to affect the phrenic nerve, so C5 and above, they're very likely to need intubation, as even an incomplete injury, they're going to tire and start to go into respiratory failure. So if that is an option that we're going to go down in terms of actively treating these patients, that is something we're going to think about doing. And obviously you see these patients can often present with shock. I'm going to come back to that a little bit, but managing that shock can be challenging. Okay, so working towards stabilization and decompression. So I've put two slides into one here. So talking about how we're going to manage that airway. So manual inline stabilization is still probably the best option. It can be challenging to manage an airway with someone in a column and blocks. You're in a fixed position. Traditionally, there was a lot of teaching towards doing an awake fiber optic for all of these patients. So that's one of the bits that has kind of changed a little bit over the last couple of years. So I think with the advances in video laryngoscopy that we have available to us with hyperangulated blades, I think more and more patients we are doing this asleep with that manual stabilization. If we can't get a view of the collar, if we can't get a view, then taking the collar off and having that kept straight is helpful. What we really want to avoid is any spinal flexion, unless obviously if there are known fixed flexion deformity, so your patients with ankle spondylosis and things like that, then obviously we're not going to try and extend from that. We'd keep them in what position they are in. You can tilt the bed if needed for an A and B reason, so we don't have to do it with them perfectly flat. If a slight incline is going to give you a better view, that's an appropriate thing to do, at least for a short period of time till we have the airway secure. But the minimal movement, the better. In terms of actually reducing, so there's a couple of options available to our surgeons. So you have a closed reduction in traction, or you have the open decompression and stabilization, which is your gold standard of treatment. It may well be that they trial a period of closed reduction in traction first. And the problem with doing an open decompression is in a patient that may have multiple other injuries, that may not have that much physiological reserve, a long, probably multiple hour prone procedure in theatre for these patients is not a small thing. That's a massive operation, and surviving the stress of the operation itself might not be feasible. And I've certainly been around awake patients where I've had to have that conversation of we're probably going to kill you with the surgery, so we can't offer it, and then how are we going to manage the bits from that. Just a quick one. Have I got any questions on the bits up to this point? Because I'm going to start to move on towards kind of perfusion and things like that. Like I say, the surgical gold standard is early decompression, early reduction, plus or minus a decompression for the best outcomes for the patient. But it's just about managing that with the other risks, the stress of the surgery itself, other injuries to the patient. Obviously, if they've got multiple other fractures, like chest trauma, this might not be a feasible thing to do. Cool. Stunned silence. Excellent. Okay, so let's talk about perfusion, because this is the other reason why they often come to ITU, and certainly why lower spinal cord injuries may come to the ITU, so things like thoracic injuries. So the spinal surgeons are going to ask for usually a map of above 85. The evidence for this is pretty weak, but it's certainly kind of the consensus expert's opinion. And the idea is that they're trying to keep as much perfusion to that spinal cord from the vertebral arteries as possible. How long for? Probably after 5 to 7 days. Any benefit you're going to get, you've got. And after that point, any damage that's come from the hypoxia or hyperperfusion has probably already happened. So after the 5 to 7 days, you can probably start to relax to more usual levels and more usual targets. But that's one that the spinal team will want to be pretty closely involved with all of this as we go through. Now, I mentioned about shock earlier, and shock's common. So like I said, common in the context of polytrauma, so hemorrhagic and or hypovolemic shock is quite common in these patients. Obviously, the treatment is to fill them up. But then you've kind of got the slightly confusing terminology of neurogenic and spinal shock that I'll come on to in a second. That just need to be a little bit careful. That will also need managing. Generally, the strategy is to obviously replace the losses. So if they're bleeding, give them blood, and then a pressor of choice to kind of help push that map up. NORAD obviously being our usual bread and butter, and that's fine in these cases. So spinal versus neurogenic shock is something that I found a little bit unhelpful terminology, or tricky to get my head round. So the basic way to think about this for me is that neurogenic shock is your true distributive shock, whereas your spinal shock is more of a sensory shock due to the actual injury. So in spinal shock, it's the loss of your spinal reflexes and function below the injury. So this is that flaccid paralysis, complete areflexia below wherever you've been hurt. You can get bradycardia and hypotension, and but that's usually neurogenic shock coming across, and spinal shock doesn't necessarily need to have any impact on your physiology. Important one here in the differentiator is that if it's true spinal shock, you'll lose your bulbar cavernous reflex. What does that mean? That means if you tug on their catheter, their anus will clench, is the bulbar cavernous reflex. So if that's absent, it's likely to be spinal shock. It usually resolves on its own after about 48 hours-ish. Your neurogenic shock is because of your disruption of your autonomic nervous system, which comes into play a little bit later as well. You'll end up with profound vasoplegia, so they'll be warm, they'll be dilated peripherally. You get loads of venous pooling in those limbs. Bradycardia, hypertension, because you've lost that sympathetic outflow to the heart. That therefore clearly needs kind of response in trying to restore that vasogenic tone. So that's where your NORAD, your other pressors come into play. Does that kind of make sense to everyone? Looking to see kind of vague nodding. Yeah, cool. All right. So then we come on to how we're scoring and kind of fully assessing that deficit. So the American Spinal Injuries Association, these are the Asia charts that kind of talk about finding a friendly spinal surgeon that wants to fill this out for you is always the best way to do it, in my opinion. They're scored on the grading from A to E. So A is a very high grade injury. E is I hope most people on this call where all of their nervous system is fine. Okay. So A corresponds to your grade 5 injuries for other scoring systems, so your spleen, your kidney. All right. So A is your complete spinal cord injury. So what's left? You've got no sensory function left. You've got no motor function left below the level of the lesion. Okay. Your grade B's are also your really kind of bad incomplete. So the only thing that's really spared is either no motor sparing or some sensory sparing. And the key one here is usually your sacral sparing. So if you've got sacral sensation, if you've still got voluntary anal contraction, that's a good sign that that is a sign that it's an incomplete injury. And then your CLD is when you start to have your motor. So it's kind of assessed on half the muscles below the lesion. So if you've got a motor score of 3 is the cutoff. So that's basically able to move against gravity. So if they can lift against gravity in more than 50%, they're said to be a grade D. If they can't, then they're a C. All right. And then I say E is normal, that's everything else. So the chart basically goes down, it's left and right, and it's all myotomes and all dermatomes are assessed. Now, if anyone like me found the dermatomes really hard to get through and remember, especially straight out of medical school, the simplest way I know to remember it is to remember that humans evolved from quadrupeds. And although this is an objectively funny image, if you imagine us as a quadruped, it's literally just stripes down from where the spine is. So yes, it's complicated trying to remember all the bits of the arm, and you can always look and cheat. It's fine. It's on the ASIA chart for a reason. But if you imagine someone on all fours, actually, it suddenly makes it a lot easier to visualize where those dermatomal levels are. Right. So at this point, we have an injury. They're secured on ITU. We're pushing the map. We've secured their airway if needed. I'm going to talk more about cervical injuries and high thoracic and cervical injuries now rather than anything else. Okay. But now it's kind of time to talk about the medium and the longer term complications of a spinal cord injury and how that impacts our management. So in terms of the complications, essentially most body systems are going to be affected by this, right? This is a major injury. So skin, pressure injuries are clearly going to be a risk now. If you don't have motion below a level, then how are you going to turn? And if you can't feel, how are you going to know to turn to take pressure off those areas? So pressure ulcers, if we're not careful, are really easy to happen. Respiratory is obviously a big one. These patients are, especially if they've got a thoracic or higher injury, as I'm going to get onto a little bit more detail, are high risk for respiratory complications. Loss of bladder function, loss of bowel function, and if they're not managed appropriately, these puts our patients at risk of something called autonomic dysreflexia, which again, I'll talk about in a little bit more detail. They're now essentially immobile in portions of the limbs, so they're clearly at risk of VTE. And the psychological impact of this injury. I'll talk a little bit more about prognosis and recovery in a little while, but these are likely to be life-changing injuries. Depression is clearly common in these patients, and helping their family through this and how the longer journey is going to look is challenging. Clearly, a higher level of injury, the more complications you would expect to experience. But for most of these, well, for all of these, prevention is better than cure. So don't treat the VTE, stop them having one in the first place. Good bowel and bladder management, try to prevent onset of autonomic dysreflexia, careful skin management, respiratory bits that I'm going to get onto in a second. If we can prevent it, that's better than trying to chase it after the fact. Right, respiratory sequelae in these patients. So the really important bit is you've kind of got 3 important groups of muscles. They're going to be affected and all have an impact on these patients' breathing. So firstly, you've got your abdominals. So the main help in this context is they're the ones you need for like cough, clearance of your secretions, so that your forced expiration. And they're the ones that are innervated the lowest, so your T6, T12. So even with a relatively, in this context, relatively low injury, this can impact that cough and clearance. What does that mean for the patients? Well, if they can't cough and clear effectively, you get more atelectasis. Your rate of pneumonias goes up drastically. So when possible, managing them in that head up position, regular suctioning, things like that nature are really important for these. Good oral hygiene and the rest. Then obviously you've got your intercostal muscles. So that's obviously helping maintain that volume in your interthoracic cavity. It's off each rib, right? So it's T1 to 11. And then you have your diaphragm itself. So we should all know the rhyme: C345, keep the diaphragm alive. This is obviously your main driver of respiration. Okay. Now, a little bit of an exercise for everyone in both rooms. So if I can get everyone, just pop a hand on your chest, pop a hand on your abdomen for me. And I just want you to take a couple of really big deep breaths in and out, and just feel what your chest and your abdomen are doing as you do that. All right, it's nice, slow, proper vital capacity breaths for me. So now I've made you all manually breathe. What I'm hoping you're noticing is as you breathe, and obviously that diaphragm flattens and moves down into your abdomen, you get some expansion of your abdominal cavity, right? So your abdominal muscles come up. At the same time, your intercostals are contracting and lifting your chest up, okay? So what happens shortly after a spinal injury is you can end up with this phenomenon called paradoxical breathing. When you've lost the tone and the nerves to your intercostals in particular, when you try and breathe of a normal breath and you make that negative pressure, you've got no tone in those intercostal muscles. So as you breathe in, what happens is your chest, rather than expanding up, will actually suck down. Okay, and so you'll actually end up with less volume. Similarly, because you don't have that tone, as the diaphragm moves down, you find the abdominal contents protrude even more. And what ends up is you should be able to see on this screen is you end up with this really odd seesaw pattern of breathing. And what I'm telling you there is when he's breathing in, that's when his abdomen's coming up. So his chest's actually falling during inspiration. Okay. So this pattern of paradoxical breathing is present certainly in the early period after a spinal cord injury. Why is this important? There is no point trying to wean this patient from the ventilator if when you go to spontaneous breathing, this is the breathing pattern you get. Okay, so over time, what happens without that innovation is those muscles in the intercostals start to tighten and sometimes even become quite spastic. So although they still then won't expand properly, but what they will do is they'll hold that chest wall rigid so that you can still generate expansion rather than collapsing and almost fighting you as you try and take a breath. Got a few nods. Does that make sense to people? Because it's a little bit tricky one to get the head around. Any questions at this point? No? Yes? Real. So then weaning. So first thing is, are the patient suitable for weaning? So we just said, has that paradox resolved or is resolving? Because if it hasn't, they're probably not going to wean and you're just going to struggle. Most of these patients end up that we think are going to struggle to wean are going to get a tracheostomy. Timing of this remains somewhat up for debate. Probably no earlier than day 7 to 10 is still reasonable. Now, if there is a plan to stabilize the neck, you would want that done first before you go for a tracheostomy. Now, saying that, patient that's had a recent stabilization, doing the tracheostomy percutaneous can be quite challenging. So this is often one where getting a friendly ENT surgeon involved is a good idea. Even if you're doing it perc, doing this in theatre would be a reasonable thing to do. And then the other things that you would for any patient. So managing pain. If they've got a VAP, trying to wean them is probably not going to be successful. So let's treat that first. All right. So then in that case, how are we actually going to wean this patient? So typically, sprint weaning has been the modality of choice on the units I've worked on. And we do this for other conditions, but we usually start a little bit more aggressively. The key with these is to go slow often and progress really slowly. So 1 minute might be too much to start with for some of these patients. Okay, it might be 30 seconds at a time with quite a long rest period between them, and then building up a minute a day genuinely for quite a few times. So we had one patient that was on 1 minute 3 times a day for a first couple of days and then slowly progressed. It is slow, especially with your cervical injuries. So one study all studies in these contexts have got low numbers, because how could you ever have high numbers? Averaged about 37 days to liberate patients from a ventilator with these kind of injuries. So this is a slow process, slow progress. And then it's making sure we do the extras. So secretion clearance. So working towards a cough assist for those patients, trying to train the accessory muscles. So there's some work with kind of TENS machines there, trying to maintain that motivation and not underestimate the psychological impact that this can have, and that this is a long old slog for those patients that are going to recover. In the medium to long term, there is potential in those patients that do have a patent phrenic nerve, so the kind of C5 and but C5 injuries and below. There is some role for a phrenic nerve pacing device, so as a nerve stimulator, and that can be one of the only ways to give them some ventilator-free time each day, and be able to help them talk and communicate, which is quite a big deal for them. Okay, I'm going to move on from weaning, unless there's any kind of questions from the group. But there's one thing to take from it. It's these are ones that we go slow and make sure they're on proper rest settings in between efforts. Cool. Autonomic dysreflexia. So this is the other kind of big one that comes up in the management. That's somewhat unique to spinal cord injury, and it can be a little tricky to understand. The best way I learnt it is that this is actually an induced form of cheating by some unscrupulous Paralympic athletes, particularly kind of the tetraplegic athletes. So with your injury, you've kind of severed your kind of reflex, and particularly in the early stages, all of those reflexes are then dampened in that spinal shock we talked about. Afterwards, what tends to happen is below that lesion, particularly with this, again, we're talking high thoracic cervical injuries here, your spinal reflexes and the sympathetic reflexes can become kind of hypersensitive. But your inhibitory pathway, so your descending pathway, is interrupted by your injury. So if you get a stimulation of a reflex below the lesion, and what are the common ones here? So a blocked catheter and a full bladder, constipation and a distended bowel, which is why kind of manual evacs and good bowel care is really important for these patients, or a noxious stimuli. So the tales from kind of from the athletics world are tourniquets around the leg, breaking a toe, sitting on a thumbtack, that would clearly trigger a sympathetic response. Without that inhibition, leads to kind of an uncontrolled sympathetic kind of storm. So what happens? You get a hypertension. As a result, they often come out of a really nasty headache, and they get quite severe reflex bradycardia. Right. So I've said before, prevention is better than cure. So good bowel, good bladder care, which are by far the most common problems that lead to this in our unit, are important. So, and removing that trigger is going to be the key to calming all this down. Then it's about managing the hypertension, and there's many ways to do that. Labetalol infusions I've seen, clonidine I've seen, whichever works. Sorry, shouldn't say labetalol. We tend to try and avoid beta blockers if possible for these patients. But yeah, managing the hypertension, so clonidine was the most common one I'd seen. The reason for avoiding the beta blockers is you're just going to make your bradycardia worse. And I know that doesn't make sense with the clonidine, but that was the argument for them. Rehabbing these patients. So high cervical injuries are likely to become at least somewhat ventilator dependent. So your C4 and above in particular, that's quite likely, and they're likely dependent on other for most of their care. As you go down, quality of life can quite rapidly improve. So the difference between a C4 and a C5 is a patient with a C5 injury often has enough in their hand and thumb to operate an electric wheelchair, so then they can actually get around off their own power rather than just using head control, which is probably all will have higher than that. C6 in particular gets tends to have a lot better quality of life, and it's as simple as that ability gives them the ability to extend and supinate their wrist so they can actually feed themselves. So C5, you can usually flex, but you can't actually bring your hand to your mouth. So being able to supinate, actually feed yourself makes, you can imagine, makes quite a big difference for these patients. Key is get them to a spinal injuries unit as soon as is reasonably possible and safe. The problem is there is a paucity of beds. So I believe it's Sheffield for us. If someone knows different, please correct me. The other close place is Stoke Mandeville. There is usually quite a long wait to get them there in a bed because, as you can imagine, once patients are admitted there to the spinal injuries unit, they are there for months, okay, months to years. Physios have got a really important role here in this long to medium term bit. So respiratory function, hand function are a really big deal for the patients. And then the psychological support, like these patients have had, this is horrendous what's happened to them. This will change their life. This will change their relationships with their loved ones. Depression is common, as I said before. So what does this actually mean in terms of prognosis? And first thing the patient's going to ask you is, am I going to get better from this? Unfortunately, well, sorry, I don't think so. Quicker to surgery tends to lead to a better recovery, provided you can get them through the surgery safely. With your incomplete lesions, the more sparing you have, the better recovery you have, which I think makes sense to people, right? So the more you had at the onset, the more recovery you should expect. Those that recover faster tend to have a more complete recovery. So those that it takes quite a long time and it's slow to show any recovery, their final kind of ceiling is usually lower than those where it happens faster. The other kind of trend that seems to run true is that once they start to plateau and kind of get stuck at a level, it's rare that you then improve further past that point. So once you kind of get to a point and things slow down and seem to stop, that probably is a stop. It's probably not just a blip like we get in some other conditions. So once you get there, you're there. Incomplete injuries, meaningful recovery is less than 1%. So really quite low. Most patients will recover to one level lower than where they had. So if your initial injury is an Asia A C5 injury, about 8 out of 10 of those patients will make it to become essentially at point of discharge a C6 injury, so to the point of being able to feed. And about 2 out of 10 of those would make it then to a C7 injury. Does that kind of make sense? So one level is the common improvement that if you're going to get any. So take home message from me. In complete spinal cord injury, meaningful recovery is really rare. So those patients with a complete high cervical injury, there is often a conversation to be had about what quality of life they would find acceptable. Someone with a high C3, with a complete C3, C4 injury, the chance of them getting any kind of independence, even to the point of like being able to move their own wheelchair with a hand or use their hands, is probably going to be slim to none. So knowing that at the outset might change how you want to progress to these patients. These patients might not want to consider with the rest of the treatment. Early surgery improves prognosis if you can get them through it safely. And the majority of what we do, as with most things, unfortunately, in ITU, is preventing secondary injury. We can't change the first, we change the bit after. But please don't forget the basics: skin, bowel, bladder care, VTE prophylaxis. Those are the easy things we can do, and they are the easy wins for us. That is about it from me. So with that, I will open it for any questions. And bear with me. Hi, Jenny. Go ahead.
Okay, so just a recommendation really. The Spinal Injuries Association website has got excellent resources for clinicians and also for patients and families. Really brilliant organisation. My aunt suffered an incomplete spinal cord injury in her 90s, and they were fantastic at helping support and advocate for her. But well worth a look, particularly for the stuff about bowel and bladder care, because there's some really good stuff on there. Thanks.
Thank you.
I've been asked to do the journal club basically for this week. My name's Luke, for anyone who doesn't know me, I'm one of the ICU trainees. So the paper that I've been asked to review is from the Rescue 3 trial. And this is a trial that looks at whether temporary transvenous diaphragm stimulation actually helps with weaning from mechanical ventilation. And it was an American study. It was published in the Journal of Respiratory and Critical Care Medicine last year. So in terms of the background and why this is relevant, I guess, is that prolonged mechanical ventilation can be caused by lots of different things. But a key factor could be because of diaphragm atrophy. So if you're on a ventilator and you're not breathing on your own, then obviously your diaphragm wastes. And then down the line, when you're trying to be liberated from the ventilator, it can be problematic. So the idea is that if we can somehow stimulate the diaphragm, prevent it from atrophying, then we can actually help liberate patients from the ventilator. And that's what this study really looks at. And the technique that they use is this transvenous diaphragm neurostimulation. So it's this kind of novel method. And basically what it is a central line that is inserted either into the left internal jugular or the subclavian vein. And it is connected to a central monitoring port. An electrical stimulus is delivered, and it stimulates the phrenic nerves bilaterally, and that causes stimulation of the diaphragm. And the overall goal is that if you continuously stimulate the diaphragm over a period, then you strengthen the diaphragm, it no longer atrophies, and this will go on and help with successful weaning. So that's the background. This is just a diagram that was in the study. The device is called a lung pacer, and you can see here that it is just similar to a normal central line. It sits at the cavo-atrial junction, and then, as I mentioned, it stimulates the phrenic nerves and therefore the diaphragm bilaterally. So what was the study objectives then? So there was the main primary objective of the study was a proportion of patients that were actually successfully weaned from the ventilator by day 30. And then there were a number of secondary outcomes that were analysed during the study. So this was things like duration of mechanical ventilation. They looked a bit at mortality. They did measure the maximal inspiratory pressures as well. And they also looked at some adverse events that occurred. Those adverse events generally related to all sort of central line insertions. So that was things like pneumothorax, hemothorax, infection, thrombosis, arrhythmias. So the study design, so it's an international study. It was predominantly in America, but there were some European centres. Overall, it used about, I think, 48 centres. It was an open label trial, so it wasn't blinded, and it was a randomised controlled trial. So the inclusion criteria, so patients had to be adult patients. They had to be ventilated or on mechanical ventilation for more than 96 hours. And they had to have already failed 2 weaning attempts. So I guess it was kind of patients that were already difficult to wean from mechanical ventilation were included in this. And then the intervention, so they compared diaphragm neurostimulation that was delivered twice a day, so that was their treatment group. And they compared that against just the standard of care, which is, I guess, daily sedation holds, spontaneous trials of weaning every day. And then In terms of their analysis, they used this Bayesian analytical approach in order to do that. The reason why they did that was because they had to borrow some of the data from a previous trial. So a similar but slightly different Rescue 2 trial, they actually used some data from that. And the participants, so there was 223 patients who were actually randomized. 109 had this cannula inserted, and they used diaphragm neurostimulation to see if this helped them wean from the ventilator. And then 114 patients were in the control group. The trial actually they had to stop the trial early because there were a few issues with finances. I think COVID also impacted their enrolment process. So the outcomes then, so the primary outcomes, so as I said, the weaning success by day 30. So the patients in the diaphragm neurostimulation group, so 70% were successfully weaned by day 30, whereas in the control group, only 60% were successfully weaned. Because they used the Bayesian analysis, whereby they borrowed data from a previous trial, they look at this posterior probability of superiority. And generally, it's considered to be significant if it's more than 97.5%. So in this case, it was significant. In order to get that significant level, so without borrowing data, it wasn't significant. And when they did borrow the data from the study previously, it did show a significant difference. So overall, the interpretation is that there's a high probability that it does improve successful weaning in this instance. And then some of the secondary outcomes, so ventilator duration, the treatment group were found to wean faster than the control group. They noted that the maximum inspiratory pressure had increased significantly in the neurostimulation group versus the control group. And there were a higher median ventilator-free days in the treatment group versus the control group, and all those values were statistically significant. In terms of the safety and the adverse effects, so with this lung pacer device, there were more adverse events compared to the control group, as you'd expect, as you just inserted another device. So 36% of the intervention group experienced these adverse effects versus 24% in the control. They found that the mortality overall was similar between the two groups. So the overall interpretation of that is that whilst it may improve weaning success, it does lead to more adverse outcomes. So the overall author conclusion was that, as we mentioned, it does improve successful weaning. It also improves your respiratory muscle strength, your ventilator-free days as well. So strengths of the trial, it's a multi-center, multinational randomized control trial. They used an appropriate statistical analysis given the fact that they had to borrow some data from a previous trial. And when you look at the endpoints, they are relevant to ICU practice, so things like weaning success and ventilator-free days. Limitations of the trial, so they had to terminate the trial early, and that therefore limits the overall power of the trial and also limits the overall conclusions that you can draw from it. It was an open label trial, so there's lack of blinding. Again, that introduces bias to the study. There were some technical issues as well that they came across, and these patients weren't included in the overall analysis. So they found that about a quarter of patients, when they inserted the cannula, they actually had difficulty either stimulating the diaphragm or actually putting in the cannula in the first place. And then because they had to borrow data from another trial, it made the statistical analysis very complicated, and they had to make a number of different assumptions when they analysed the data. So the overall bottom line is, I guess, would you use this diaphragm neurostimulation device in ICU? So I think there is clearly this provides evidence or supportive evidence for using such a device. However, I think in reality there needs to be more clinical trials on this that are higher powered. You have to be careful because there were a number of adverse events following insertion of the cannula, and therefore we couldn't really recommend it for widespread use in ICU without further robust evidence.
Is there any data on how many of these patients were spontaneously ventilated or mandatorily ventilated? Was there any mention to these?
As in
the original paper, so was there any? So around 100 odd people were in the intervention arm, isn't it? Is there any data as to how much proportion of them were mandatorily ventilated with a neuromuscular blocker, and how many of them were spontaneously ventilating? Because there's multiple.
So they were all patients that had already had attempted spontaneous breathing trial.
Breathing trial and failed.
And they failed basically twice, so at least twice. So there were people that were already considered that they should have a spontaneous breathing trial. So they had already optimized other values before.